Greetings of the day, folks. In this video, we shall discuss about pneumonia causes that are age specific and also pathogen specific patterns of the disease. When we look into pneumonia, when we start from the birth, so the neonates require special consideration because they're at risk of acquiring, bacterial pathogens that are acquired perinatally. And the organisms most specifically in this age group will be group B strep, gram-negative enterobacteria such as Klebsiella, E. coli, and Listeria. And in, if we consider the late onset pneumonia, neonatal pneumonia, they may be acquired by the environmental organisms like the neonates will be surrounded by the various pathogens that are most commonly seen. That will be staph aureus, strep pneumonia, and strep pyogenes. And pneumonia due to maternal genital chlamydia trachomatis in developed countries has been largely eliminated, but they are still seen in developing countries. And if we come to the infants between 30 days to 2 years of age, infants and also children, these are usually viral rather than bacterial. And the most common viral illnesses that are seen in this age group will be respiratory syncytial virus, rhinovirus, influenza, parainfluenza, and etc. And in bacterial, strep pneumonia is the most common. And in other bacterial infection, Haemophilus influenza can be seen. That is most commonly typable B and also non-typable B. And less commonly, but most important, is the staph aureus group A strep can also be seen, and Bordetella is also one of the most important causes. And in children of age group 2 to 5 years, the most common acquired pneumonia is respiratory viruses respiratory syncytial viruses, human rhinovirus, human metapneumovirus, and other bacterial like strep pneumonia, human influenza type B, and non-typable influenza. And in less than, the chlamydophila and also mycoplasma are less common. And the pneumonias due to varicella zoster, measles, Haemophilus influenza type B, perivertebral pertussis are increasingly rare in areas of widespread vaccination and herd immunity. And in children of age 5 to 13 years, mostly while usually virals predominate, but some of the atypical infections can also be seen, such as mycoplasma pneumonia, and also other can be seen. And chlamydia pneumonia and strep pneumonia remain important consideration. And some other less common will be staph aureus, and the group is strep and non-typable human influenza and legionella. And in case of pertussis, like immunity from the acellular veins over the time, so Bordetella should be considered if clinical symptoms are strongly suggested. And the proportion of pneumonia cases with any detected pathogen increases with age, from less than 10% in young children to about 35% in adolescents. So in adolescents, again, most common will be similar to the what we see in healthy adults. Strep, pneumonia, and other common causes will be seen in this. And in some cases, some role of atypical agents can be seen and estimated to be with the significant, but data and the guidelines from other parts of the industrial country suggest regional differences can be seen. And in case of pathogen specific patterns, so in general, it is not possible to pinpoint specific causative organism by clinical findings alone. So, if we have, what we mean by typical is that they are present with high fever, chills, pleuritic chest pain, and productive cough. If, when we say atypical pneumonia, they usually have a gradual onset over days to weeks. They have low-grade fever, non-productive cough, malaise, and suggest infection with mycoplasma and chlamydia pneumonia. And wheezing in children with an acute respiratory infection may suggest bronchiolitis, viral pneumonia, or mycoplasma. Despite these limitations, some patterns of the disease do suggest certain etiologies. So in this table, we can see the patterns of the disease by specific pathogen. So if The infective agent is the Staph aureus. Usually we see is that rapid onset, high fever, toxicity, and pulmonary abscess can be seen. And if there is a like a concurrent influenza, it can predispose to secondary staph aureus. It will increase the risk for the staph or pneumonia. And chlamydia trachomatis, the disease characteristic will be the patient will be having staccato cough, diffuse rales, and febrile pneumonitis. And sometimes we'll see V's and bilateral infiltrates. It is usually primarily seen in neonates and young infants, but rare with the prenatal maternal screening and also treatment. And in case of mycoplasma pneumonia, the predominant symptom will be the hacking, dry cough, headache, and sore throat. And in some school age, it can cause wheezing. And extra pulmonary symptoms can be predominantly seen, such as arthralgias, rashes, and CNS involvement can be seen. And in Bordetella pertussis, the upper respiratory prodrome followed by paroxysmal cough, that is whooping cough, can be seen. And there can be gasping, stridor, and color change because of the persistent cough. And this cough may persist for months. And the Mycobacterium tuberculosis will have a prolonged fever, cough, and also fever that will be low grade with evening rise of temperature. And there could be extra pulmonary spread. And we should consider Mycoplasma tuberculosis in children from endemic areas and those with a known exposure. Classic symptoms seen in adults may be absent in children. In case of respiratory syncytial virus, the upper respiratory symptoms will be predominant, and sometimes you can see the cough, wheezing, rales, and bronchi. And clinical diagnosis of the classic symptoms in children less than 2 years old, seasonal epidemics can be seen. And staph pneumonia, which may follow influenza, is notorious for rapidly progressing symptoms, high fever, toxicity, and presence of pulmonary abscess. Chlamydia trachomatis infection in infants, which is rare, where there is a perinatal screening and treatment, often presents with staggered cough, diffuse rales, and sometimes we can see scattered rales and rare wheezes and also bilateral infiltrates. And sometimes older children may complain of sore throat and dysphagia. We should consider the Bordetella pertussis and also respiratory viruses are also implicated. So, as we have already discussed this, and if there is severe disease, the criteria for severity of illness are not well defined and severity scoring have not been validated. So, the guidelines include high fever, hypoxia, and signs of respiratory distress as potential markers of severity. And in case of a young age, vital sign abnormalities, chest retractions, and multilobar radiographic infiltrates have been associated with more severe disease in hospitalized children with pneumonia. Clinicians should determine severity in the context of physical exam findings and also laboratory and imaging studies. So the differential diagnosis include so when there is a severity in the context of you should have a overall assessment for determining the severity of the disease. And coming to the differential diagnosis of pneumonia patients, it includes both infectious and also non-infectious, as well as extrapulmonary disorders that may mimic or complicate lower respiratory tract infection. So, in infants and also young children, formulating is especially important because we have many differential diagnoses and we can't be sure of anything, and there are many mimicking uh, diseases that will be having. So we should differentiate each and everything. So congenital heart disease may present with cyanosis, quiet tachypnea, and also respiratory stress, and small breathing such as DKA or other metabolic diseases. And toddlers are particularly at risk for foreign body aspiration and ingestion of toxins. And adults may intentionally or unintentionally take drug overdoses that speed or slow breathing. So the differential diagnosis of pneumonia in infectious causes obviously will have upper respiratory tract infection and otitis media and bronchiolitis or croup. Then in non-infectious causes, foreign body aspiration, then inhalational pneumonitis, such as hydrocarbon inhalation or chronic gastroesophageal reflux disease, and also intoxication and congenital disorders, anatomic abnormalities such as congenital lobar emphysema, pulmonary sequestration, and TEF, then neoplasms and pulmonary embolism. In extrapulmonary causes, sepsis, cardiac abnormalities, and also endocrinopathies, neuromuscular disorders, and inborn errors of metabolism and other GI emergencies can be seen in extrapulmonary. So you can remember it as this is a diffuse one which involves the blood and also the other organs. This is the heart, then other neuromuscular is this other system, and endocrinology is one system, and also GI. So head to toe you can cover in extrapulmonary causes. And non-infectious, normal inhalation, intoxication, and congenital anatomic and neoplasm and pulmonary embolism can be the other causes of the features that are seen in the LRTA pneumonia patients. Thank you very much.